Hello and welcome. This is yet third in a series of fireside chats brought to you by ADI. For those of you unfamiliar, I can tell you that ADI has been around for 40 years now. This is our 40th anniversary. We're an umbrella organization of 105 member countries around the world, and we represent our members at the World Health Organization, the United Nations, the Organization of Economic Cooperation and Development, just to mention a few. Probably best known for our World Alzheimer report that comes out every year. Okay, let's go to the next slide, if we will. This, of course, is a fireside chat, virtual. We have no fireside, which is probably a good thing. We have no fireplace as well. It's our way of saying these webinars are conversational in style. We hope that will allow us to dig a little deeper into some of the key and challenging areas for a full and frank discussion about issues involving Alzheimer's disease and dementia. And if you have a question, a reminder, please add it to the Q&A box. That's the Q&A box. If you have a question, we'll try to get to those near the end of the program. New slide, please. A perfect opportunity for me to remind you of our upcoming international conference in Krakow, Poland. There is still time to register. There's always time to register and join us for what will be an insightful, innovative, and inspirational conference. If you do come, you will never regret it and go away. I think a little more empowered in terms of your work in this field. New slide. Just remember that our mission is to make Alzheimer's disease, dementia, make it a world health priority. And we always appreciate your donation to help us get there. Next slide, please. And here are the likely candidates of my two guests. You're going to hear more about them in just a few moments. And what I'm going to do is set up the topic so we know precisely what we're talking about. So let me offer a few thoughts. Today, I think news reports on the fight against dementia are more and more likely to include such words as imminent breakthrough, as we enter a world of disease-modifying treatments and faster, less invasive, cheaper, more accessible diagnostic tools such as blood-based biomarkers, a blood test. What happens then to the provision and improvement of good quality care for the millions of people living with dementia around the world? Is there a risk that these new treatments could divert attention and resources away from the development and rollout of meaningful, efficient care plans? So I'm really asking if the focus is shifting. Our governments, healthcare systems, the media, focusing more on earlier diagnosis, drug treatments, risk reduction, pushing care planning and access to post-diagnostic support, well, maybe to the back burner. ADI estimates that 85% of people are not accessing post-diagnostic care. And this happens even in high-income countries with developed national plans. Access to meaningful, useful care. It's complicated, patchy in some cases, costly, with agonizingly long wait lists. So then, how do we measure the threat to care and care planning? This unintended consequence to medical progress. What does a fair and balanced model of both dementia treatment and dementia care, what does that really look like? And lastly, what does it mean for policy? Where should our attention and advocacy be directed now? What kind of questions does it raise for Alzheimer and dementia associations? As you can see, I have a lot of questions. My guests, Professor Sube Banerjee. Sube is the Pro-Vice Chancellor and Professor of Dementia at the University of Nottingham in the UK. He has long worked in national and international health policy and is an applied health researcher focusing on quality of life and quality of care for dementia. Sube is a member of ADI's medical and scientific advisory panel. Professor Dame Louise Robinson. Louise is Professor of Primary Care and Aging and Regis Professor of Aging at Newcastle University in the UK. Louise's research program is focused on improving quality of life and quality of care for older people, especially those with dementia. Professor Robinson is co-chair of ADI's medical and scientific advisory panel. All right, to some questions now. Sube, you recently published an article in a special edition of the Journal of Dementia Care. The headline was, "Be alert to this assault on dementia care." Tell us why this is such a pivotal moment for dementia care. Tell us about this assault.
Thank you. Well, I think sometimes it is important to use arresting language that draws attention to particular moments where there are choices, the possibility of change. I think we've got to be really careful that we do not have unintended consequences in terms of producing worse quality care for dementia when we have fantastic opportunities ahead for ourselves. So for me, there are two things that we need to be careful about. The first is the lure of the shiny, and the second is about a flight to simplicity. So the lure of the shiny is so powerful for policymakers, it's so powerful for politicians. And basically what we have is something that's happened which is brilliant and amazing, which is the development of the first generation of disease-modifying treatments and some fluid biomarker stuff that's really important. What those are is a fantastic proof of concept. What they are is a brilliant scientific, the start of a journey scientifically in terms of dealing with dementia. What they are not is an answer to the problems of dementia. They're a partial answer to a small part of the question that's there about Alzheimer's disease. And I think the lure of the shiny is that gets so exciting and the costs of them become so entrancing that also dazzling, that you take the small amount of resource that we have at the moment associated with care and you put it into the delivery of those drugs to a very few people with Alzheimer's disease, and you forget about care. And the flight to simplicity complements that, unfortunately. So we have a complicated story that we tell about dementia, which is about how important it is to know early, how important it is to support carers, how much can be done by non-drug treatments. What we have now potentially is this flight to simplicity, where the complex problem that is dementia appears to have a simple answer, which is all you need is these drugs to treat them. And to diagnose them, all you need is the biomarker. Neither of those are true at the moment. And the people who would lose if we work like that would be the vast majority of people with dementia who will not benefit from those treatments.
Louise, what's your perspective on this, on these new treatments and diagnostics and what they're going to do to the world of care?
Well, I think for once in my life, I agree with Sube. So I could say I just echo what Sube says. But actually, I think it's very important to dig a bit deeper into some of the things he's alluded to. And I think one of the current challenges is the current status quo and the current inequalities that you've alluded to, Dale, that exist in people's access to post-diagnostic care and support. We know that actually both within countries and across countries, there are huge inequalities in access to what is already proven good quality care. So, for example, in the UK, for example, these may be at a geographical level, something that we call postcode lottery, where people who just live a few kilometres from each other are getting very different services. They're exacerbated when you're talking about between cities and remote and rural areas, and then also between the different types of dementia. So, for example, people with young onset dementia or the less common types of dementia often find it hard to access good quality care and support. So many of these things are also seen in lower middle income countries, the same key concepts, even with different health.
To both of you, how do we ensure that governments and health systems don't divert their resources, don't follow the shiny object or the newish things that grab our attention, particularly the media's attention, may I say? How do we prevent that? We know that, for example, in most countries, care is already a hit and miss, under-resourced kind of thing. How do we ensure that care, and remember that's a key part of Action Area 4 of the World Health Organization Dementia Global Action Plan, how do we ensure that that remains at the heart of any response? What do we actually do, Sube?
Well, I think that what we need to do is make sure that when we talk about one, we talk about the other. So the shiny thing is really important because you can use it as a lure to attract your politician and your policymaker. But once you've caught your policymaker with the lure of the shiny, what you then have to do is give them the proper information about the fact that the bold, important and useful things that you can do for people with dementia that will release the economic costs of dementia are all about delivering great quality diagnosis that are about giving these new treatments, but are also about brilliant post-diagnostic care that enables people to live their best lives. And so it's a slightly more complicated message. It is that we need these new shiny things, but we also need the slightly duller, but much more powerful things that are about supporting family carers, that are about supporting with people with dementia, to let them live the best lives they can with their dementia.
And those duller things, as you say, are so important to families who are living with dementia in each and every country around the world. Louise, what action do you think should be taken?
Well, I think, building again on Shube's response, I think it's important to remind, once we've lured the politicians and the policymakers in, it's important to remind them about the evidence. So I think, first of all, we know, for example, in the UK, we have, a document on clinical excellence in dementia care that has summarised all the evidence to date on what works and what we know about evidence-based dementia care. And that was just updated in 2018. So we can say we already know much of what makes for good quality post-diagnostic care before these shiny new treatments came in. We should be ensuring that that is core and that is implemented into routine practice in addition to those who can get the shiny new treatments. I just use an example here from other conditions. So, for example, if someone's diagnosed with diabetes, whether they are allocated a diet-only plan or a medication or insulin, that doesn't mean to say that they don't get access to a dietitian or to an optician to check their eyes. They get a standard evidence-based programme of care that ensures their current health and also and prevention of complications in the future. The people who are on insulin don't just get access to that care. So it's about ensuring we don't have a two-tier system that's introduced here with the shiny new treatments.
I mentioned the Global Action Plan a few moments ago. Let me just explain that one of the key reasons ADI has been leading the call for an extension to that Global Action Plan, it expires this year, is to make sure that Action Areas 4, that includes care and support, and 5, that's support for caregivers, for carers, that they form a solid foundation of national dementia plans in each country, that they are not forgotten. Now, the situation is that just 39 member states have created national dementia plans so far, a discouraging number to be sure. But we are seeing progress with 20 more countries in development right now. So that's why we need the extension. It must continue. So the idea of national dementia plans doesn't just fade away. We're hoping the extension, in fact, will be discussed at World Health Assembly in 2025 next year. So our fingers are crossed. Now, both of you are based in the UK, but I really think you both have a global perspective on the challenges of dementia. Could you give us your thoughts on the threat that not having a dedicated dementia plan in England will have, with plans to absorb it into this major conditions strategy, MCS, bury it, to my way of thinking, in bureaucracy? What lessons might be learned from other countries if they are considering this kind of route? Sube, can you start us off on that?
Yeah, I think that I've been around policy and dementia for a while, and I have never seen a generic policy that delivers for dementia. Whether it's an older person's policy or a long-term conditions policy or a this policy or a that policy, generic things generally don't work. So policy matters. And for me, it is a great concern that England, the government in England, the Health Department in England, have rowed back from a commitment that was made for a 10-year comprehensive strategy on dementia, which I think would have changed things for people with dementia, big time, to this slightly ill-defined, non-specific major condition strategy, which includes not just dementia, but cardiovascular disease, chronic respiratory disease, mental health conditions, cancer, and dementia. And that generic approach will disadvantage and increase inequalities for dementia because the evidence base on which action will happen is so much more advanced for cancer and heart disease and mental disorder than it is for dementia. So I have the fear that these generic approaches will entrench the inequalities that we have and increase the inequities that are there between people with dementia and others. And there's some really good, laudable reasons why people want this generic approach, but they're bad for dementia.
Mm-hmm. Now, Louise, I'm wondering if you think other countries would be tempted to go this route as well, somehow shovel all this stuff together under one heading. It sounds bureaucratically neat, but it certainly doesn't sound very useful in the Alzheimer and dementia world.
Well, I think let's try and take a more positive approach, shall we? I think the first thing to say is having a plan is only a first step. So it's great to have a policy plan, but that's got to be followed by implementation, and it's got to be followed by commissioning and action to put those recommendations into actual practice and make a difference. One of the possible advantages of lumping things together is that you then get to say, how does care and services for one of those conditions, i.e. dementia, compare with the other long-term conditions that are in that bill, such as cancer and diabetes and cardiovascular disease? And I think if you did that, if you took an independent look, certainly in the UK, so for example, all people who potentially have cancer in the UK, are supposed to have a 2-week referral pathway to getting a diagnosis. Now, we know that pathways to diagnosis for people with dementia in the UK is hugely variable. We know it's much longer in many places than it was post-COVID. So you could say that lumping together these major conditions is actually a way of reducing inequalities, because you're then comparing standards between conditions. But then I did say I would try and take an optimistic approach.
What do you make, Sube, of Louise's optimistic approach? Is there room for some of her argument in your world?
Yeah, so I think that if you have the idea that you will go into this with the idea of levelling up so that the best that is available for each will be available for all of those conditions, that's great. I have a concern about the degree to which an implementation plan for something as big as this becomes anything more than quite general injunctions rather than things that are quite specific. I fear also that one of the reasons for having decided to go down this more generic line is to avoid specific targets that are measurable, specific targets that can be quantified and costed, and then specific targets that can either be achieved or not. I think we are likely to enter into a world where it's much more about generalities rather than about specifics. And the stage of development of dementia services is not one where the general is likely to be helpful. I think that there are specific things in terms of, being clear about how diagnoses are made for all with dementia, that are clear about what people can expect post-diagnostically in terms of services, so that you don't have, and that to be available across countries, territories, as Louise said, in order to avoid that all too common postcode lottery that we have at the moment. Good people will do good things with things like this. I have a fear, though, that there will be other brighter, shiny things within the world of cancer and heart disease that will distract people from the importance of acting in Alzheimer's.
Okay, I have a question now online that I think is appropriate at this point from Amina. And she asks, how do we give the relevant right information to families when they hear about new treatments and so-called cures, when they should concentrate on the care of the person with dementia? How do we get the right information directly to the families? Louise, any thoughts on that?
I think one of the key things for me is actually trying to ensure that what organisations like ADI and more nationally, Alzheimer's in England, Alzheimer's Society, the information they put out is accurate and based on fact. So, for example, in terms of the new treatments, the information that is given is based on what we know at the minute about the effectiveness of those treatments, but also the side effects and the issues and challenges that they bring. So it's a very balanced view. And we must be careful not to, although it's very exciting, we must be careful not to overemphasize what is yet not proven, if you like, in terms of what the opportunities might be in the future. So I think it's about ensuring that a balanced message that is based on evidence goes out.
Sube, let me add an additional challenge here that complicates the issue, but I think needs to be spoken about, and that's that we ensure that we address the deep injustices and inequalities faced by people with dementia and their families. But how do we also ensure diversity and inclusion in the development and deployment of that very precious care?
Yeah, it's so important that we don't rob one set of people in order to pay others within the group, to steal from dementia as a whole in order to give to those people who are biomarker positive with Alzheimer's disease that is treatable under these protocols. I mean, I would say that the amazing work of the past decades that we've had, which ADI has led in terms of moving dementia from obscurity to light, that's been powered by that acknowledgement of deep unmet need. That's been powered by the desire for there to be equality and to acknowledge the diversity of experience of dementia across the world and between dementias as well. And I think that there has been really major advances in terms of public understanding of dementia, in terms of dementia coming out of the shadows. I fear that much of dementia may be put back into the shadows unless groups like ADI, groups like Alzheimer's Society in the UK, continue with the brilliant work that they do, speaking up not only for the science has so many people who will speak for them, but also for the power of care, the importance of families, the importance of an approach that doesn't leave people behind just because they don't have a particular biomarker positively, for example. And I absolutely believe that that voice of people with dementia, that voice of carers of people with dementia that comes from organisations like ADI can absolutely make the difference across the world, so that we get policy that prioritises care and treatment, making the case for more resource for dementia, not just switching around what little we have.
Louise, let's look into the future a bit, if we can, with the anticipated increase in these treatment options. What would you say the ideal post-diagnostic team could or should look like in the future? How would that change?
So Dale, I think I'd slightly change the emphasis of that question a bit. I'd say let's look at what is the ideal post-diagnostic care and support.
All
So
right.
not the people, but actually what is the actual care pathway that should be delivered. So in terms of the components of that, we know a lot about current evidence, such as having a named lead person, an advisor or a named professional to help to coordinate care. We know about tailored support. We know about non-drug interventions like reminiscence and cognitive stimulation therapy. So we know a lot about what should constitute the best post-diagnostic care pathway. How it's delivered, I think we know slightly less about, although there is emerging evidence, for example, case management, specialist nurse-led approaches such as case management in primary care can be potentially a very effective and efficient way of doing this. But also we have to be cognizant of the fact that in many countries, there is a very, very limited specialist workforce, and much of this care will have to be delivered by primary and community care teams. And even within countries, the amount of specialists, for example, geriatricians or neurologists and old age psychiatrists, can vary between areas. So I think the key thing we've got to get right is what is delivered and making sure that it's evidence-based and person-centered, and that it goes from the point of diagnosis all the way through to end of life, not just the first year after diagnosis. And most importantly, that it's integrated, it's joined up and easily accessible.
Right. I'm sure we all agree that we aspire to robust dementia plans wherever they can be had, but how can we really engage governments without, scaring them about the sheer scale of investment needed to tackle this massive health challenge of dementia? How do we talk about trillions of dollars without being shown the door? How do we do that, Sube?
So I think we need to go back to basics. We've been at it for quite a long time, and let's remember the things that enabled us to be able to start to make the case for dementia plans worldwide, 15 years ago? Mm-hmm. The economic cost of dementia is already gigantic in every country where there are people with dementia, and that's every country in the world. The systems, health systems, social services, families already spend gigantic amounts of money and time with people with dementia. That's the first step. There's a lot of it about it costs a lot. The step after that is to acknowledge that the systems everywhere are unoptimized, and that if we were to optimize those systems with all the things that Louise has been talking about, then we would have more cost-efficient, more cost-effective services. The problems that many developed countries have of people with dementia being in general hospitals, that can be prevented. Their stay in hospital can be minimized. The harms that accrue to dementia and the costs that come through transitions into care homes that are unneeded, for example, those can be prevented by good quality care, by preventative work. So I think that we need to kind of go back to basics and make the case for the size, the importance of dementia, and for the fact that there are already brilliant things that we can do that could bring those costs down if we applied them at scale, and that would also improve the quality of life of those individuals.
Now, I'm almost out of time, but I'd like to get in one more question from online. Here's a question from Mary, who says, in my professional experience, families and individuals living with dementia need hope, as we all do. What messages of realistic hope can we give them at this juncture? Louise, I'm going to give that one to you.
I think the key thing is that we already know a lot about what works well. So we could certainly, as Sube said, we could certainly improve things in the current situation for a lot of people by just trying to get into practice what we already know and what evidence tells us. I think the future is certainly optimistic with the new tablets, and it's very much a start. And I think it's about balancing. It's about ensuring balance between investing in those new treatments and investing in the current suboptimal care systems.
Sube, can you address that question quickly?
Yeah, I mean, there is hope there. It is absolutely possible to enable people to live lives that are as good as they possibly can with the right support for the people with dementia, which generally comes from families, as well as in pivotal situations from health and care services, and the right support for people with dementia as well. And as Louise said, we could do that now if we had if services were set up to be able to do that. And if we did that now, people would have a better quality of life. Countries would use their scarce finances better, and we would be able to incorporate all of the brilliant new shiny stuff that's coming along, as well as care. I come back to the thing that gives hope is the idea that we have both care and treatment, and that treatment is some shiny stuff and also a whole lot of stuff that we can already do now.
Louise and Sube, thank you very much for your insights and for sharing with us your vast knowledge and experience. And thank you to everyone else for listening, for watching. That's the end of our fireside chat. I hope you enjoyed it and got some useful information from it. Goodbye for now.